Jo, thanks for joining me today. As you know, I've been inundated with questions from my followers about breast surgery, and some of it is really relevant to now because they've been affected during COVID times. So I've got a few questions, if you don't mind. But first of all,
of course,
if possible for you just to run me through what are the different surgeries that women have when it comes to breast cancer?
Okay, so for breast cancer surgery, we in general divide the surgery into breast conserving surgery, where we're aiming to remove the cancer with a rim of normal tissue around it, or mastectomy. So if we start with breast conserving surgery first, if you go on any of the American sites, they'll talk about a lumpectomy, but in the UK we call it a wide local excision. So the plan is that you're going to take away an area of the breast where the cancer is, but you need to have a rim of normal tissue around it to make sure that you have effectively removed it. And depending on where it is in the breast will depend a little bit as to how the approach to this is. So an oncoplastic breast surgeon will never put a scar anywhere where it's particularly obvious. So often we operate with a scar around the areola or around the edge of the breast. And from there, we will find our way underneath the skin to where the cancer is. And when we think about whether you'd be suitable for breast conserving surgery, we are looking at two things. We're looking at the size of the cancer, and we're looking at its relationship to the volume of tissue you have in your breast, because you need to have enough other tissue available to leave the breast with a nice looking breast shape. So if you're suitable for it, you will be offered a wide local excision. If you have a slightly larger cancer, or a cancer that is in one quadrant of the breast, and then you need quite a lot of remodeling of the breast, we might talk to you about things like a therapeutic mammoplasty. So that's where we remove a larger area and we remodel the breast at the same time. So we might offer you something like a breast reduction at the same time. So breast conserving surgery can be from a very small, discrete procedure that can be done as a day case, all the way up to complete remodeling of the breast, but keeping the majority of your breast tissue. And the aim for that is to make sure that we leave you with a nice breast shape. The more remodeling we need to do, the more we need to think about what we're going to have to do to the other side to make you match. And if you are not suitable for breast conserving surgery, or you elect for it, you would be thinking about a mastectomy. So the indications for mastectomy are sometimes related to the size of the cancer, related to the size of your breast. It's related in part to where the cancer is. So if it's sitting behind the nipple areola complex and that has to be removed, we may tell you that it needs to be a mastectomy. It might be because you have small volume of disease, but it's spread over quite a long area. So we can't make the breast into a Swiss cheese and do lots of little wide local excisions. We would need to think about a mastectomy because we need to take that whole area. It may be because the disease is too close to the skin or too close to the muscle. And finally, it may be because you have a significant family history and therefore we feel it would be more sensible for you. All of these things are for discussion. Women who develop a breast cancer, regardless of the size of it, may elect to have a mastectomy because they would prefer that rather than a breast conserving surgery. Breast conserving surgery is on the whole paired with radiotherapy, but not always. It depends a little bit on the pathology. And for a mastectomy, you may avoid radiotherapy, but you may not. So it's a little bit variable. Mastectomies are very often paired with reconstruction in the immediate setting. Not everybody is suitable for that, otherwise in the delayed setting. And some patients may choose not to have a reconstruction ever, and that's also perfectly acceptable. It's all about patient choice.
I've had a few questions as to, for example, there was one lady, Anna, who said that she's a size 8. She's got size 30G breast. She had cancer in one side, so she just had one removed. Now she carries around a very heavy prosthesis on one side. Could she have surgery done on the other breast to
all patients are entitled to what we call symmetrizing surgery. So that is to try and make one side look like the other. So for some women, for example, if we've done the operation via a breast reduction style, we would need to think about reducing the other side to match. If someone's had a mastectomy and they don't want to have a reconstruction, or they're not suitable for it, then the options that they have to try and improve things for the other side. So for this lady, Anna, I mean, I haven't met her, but what I would be thinking about would be whether she would benefit from a breast reduction on the other side, so that she still has her breast and we make it a nice shape and a nice size to fit to her frame. And then she would have a much smaller external prosthesis for the other side, which would be less heavy. The other option would be, if she really wanted it, would be to have a mastectomy on the other side without reconstruction. In order to do that, most hospitals have a policy that you need to meet the psychologist and be really sure that it's something that you want to do. So there are definitely options for her.
Yeah, that would be quite a big thing, I think, to go through, wouldn't it? So I think the psychologist thing makes total sense.
Yes, and a breast reduction is not a difficult operation to do. You're in hospital, sometimes it's a day case or a one-night stay. Some people don't use a drain, so it's not something that is that difficult. So it would be a good option.
And is that available on the NHS?
Yes.
Right. Okay.
It is part. If you look at the documentation, symmetrizing surgery is available, and it's not time dependent. So it's very clear that patients may not know exactly what they want at the time that they have their diagnosis, and these things take time for you to adjust to. And so it's very clear in the documentation that it's not time dependent, because people adjust to their new shape and size, and also need time to get over any other adjuvant treatments. So certainly it is available. I think that we need to be mindful that after COVID, and while we're in the recovery phase, there will be a system of prioritization. So the urgent breast cancers and time critical surgery is going to be done first, but that doesn't mean that we won't be able to offer these things in due course.
Right. And would the same go for, so with me, for example, where I've had an expander put in on my right hand side, my right breast sits very up high and pert compared to my 41-year-old one that's fed 3 children, and so I'm a bit like that, and a lot of other people that say the same. Can you have a similar sort of?
Yes. So for you, or for someone like you, symmetrization surgery may mean that we need to do a lift. So it may be that actually in a bra your volume match is good, but outside of a bra you feel that things don't match, and therefore what you need is a lift on the contralateral side.
Oh, a lift.
It may be that actually the volume match isn't great either, and therefore you prefer to have a little implant and a lift. So all of these things are part of symmetrizing surgery, and they are available. Women sometimes find it very difficult to ask for these things. I think that they have the impression that they should just be grateful that they're well, and that it's a vanity thing, but I really don't feel that way. I think it's extremely important that we make people feel as good as they possibly can, both dressed and undressed. And I would like women to be offered this surgery.
I think you're absolutely right. It's a bit like when you go through the fourth menopause afterwards, you feel like you shouldn't complain or moan because we're lucky to be alive. But equally, there shouldn't be a death sentence. And we've got
I mean, all of the treatments that you've had is for living with, life is for living, and it's important that we try and find a pathway for each individual patient so that you can have the very best adjuvant treatment, but with good symptom control. So I really feel passionately about this, but I think it can be very difficult to voice these things in the clinic when all you want to know is that you're okay and nothing's come back. And then you feel it's a bit difficult to broach the fact that actually you're having significant side effects from your treatment, or you find it very difficult that you're not symmetrical and you're dressing to hide that all the time, or you don't want to take your children swimming, or find a summer holiday very difficult, or all of these things. And if you're very unbalanced, like Anna, the lady you said, then actually it starts to affect your back because you're compensating all the time. One side is very heavy and the other side has no weight to it. So these things do have long-term effects, and it is important that we address them.
Yeah, absolutely. Now, another really common question that I got was about cording.
Yes.
I didn't know that cording existed, if I'm honest. I haven't suffered from it. Are there any tips of what people can do to help with cording?
So most hospitals nowadays will have a physiotherapy department, and within that they may have someone who specializes in oncology physiotherapist. So there should be someone in your local hospital who has an interest in this. And actually there are some things that you don't need regular physio, but you do need to spend some time with the physio understanding what exercises you should be doing. And sometimes there's some massage that they can give in the area as well to break down the scar tissue and the cording, and that can make an enormous difference. Again, people can have long-standing pain, which actually we can manage quite well as long as we get you to the right specialist. So it's not really the surgeons that manage this, it is the physiotherapy department, but it's important that you make sure that you can engage with them. So your breast care nurse should be able to point you in the right direction.
That's great. What is cording, just so I understand it?
So it's related to surgery, usually in the axilla. So we don't see it so much with a sentinel node. It's more common with an axillary node clearance, although that's not to say it's impossible with a sentinel node, and it doesn't mean that anything's gone wrong. It's just the way that you've responded to the surgery. And it's related to the interruption of the lymphatics, and you end up with a feeling of tightness and almost like a string that you can see in your axilla and sometimes right down your arm, and it
so here,
very uncomfortable.
In here,
yeah,
right,
exactly.
Okay.
Exactly, and going up towards your elbow. And then interestingly, at some point or another, it sometimes pings and you actually feel it ping and then it disappears.
Oh, wow.
So I think it's something that can be extremely uncomfortable and anxiety inducing if you haven't been told about it, but it usually is quite short-lived.
Yes, okay. Now, Ria Morgan has asked, I'd love to know, what are the reconstruction options? What are they for those who have had a mastectomy and no reconstruction because of COVID? She was told that implant options may not be possible because there won't be enough skin to form a capsule.
Yes. So once you've had a mastectomy without reconstruction, and you need a delayed reconstruction, then very often, although in some patients we may be able to manage it without, we need to think about using an autologous reconstruction. So that means using some of your own tissue, which we're going to move into the area to make a breast. So there are various options. This is commonly done by the plastic surgeons, although some of it can be done by the breast surgeons. And there are various different ones. So one is a DIEP, and that's where we use the lower tummy. That's often a very good sell because we all know that gravity is not our friend, and over time, especially with some of the drugs that we give patients, we end up with a little bit more tissue around the lower abdomen than we'd like, and it can be quite difficult to shift. So we can use that tissue to make a new breast. So that always feels like a bit of a good trade to me, because you lose the bit of tummy that you don't want and you make a breast. It's a longer scar than it would be for a tummy tuck, and not everybody is suitable for it. You need to have the blood vessels in the right place. You need to be fit enough to manage an operation that's going to be 6 to 8 hours long. You need to think that you're going to be 6 to 12 weeks recovering. Having said all of that, once it's done and it's in place, it requires very little servicing. So it's not like an implant, which may need to be exchanged. Usually once it's done, it's a long-term option, and it's your own tissue. So there's not so many problems that you can have with implants in terms of infection and loss of the reconstruction. So it does work very well. If you're a smoker, it will be not something that the plastic surgeons will want to offer you. You can use tissue from your inner thigh. You can use tissue from your inner thigh. For some women, the inner thigh is not the area that we are most proud of, so we're quite happy to use that. Yeah. And you can use tissue from the back, bringing it through the armpit. That's safe and robust, but it sometimes needs an implant as well.
Okay. Okay, that's really interesting. It's great that there's options